Hello and good morning. Welcome to the first webinar of our Beyond Blood Sugar, Improving Kidney and Lipid Care in Diabetes webinar series. These are hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. Of note, on March the 4th, we will have a third webinar that will focus on your diabetic dilemmas. So as we go through this presentation and in future, think about real-life cases that you're dealing with and submit them to us, and we will incorporate those into our March 4th presentation. My name is Donna Manca. I'm a professor emeritus, a family physician, a network director of the Northern Alberta Primary Care Research Network, the director of quality improvement in the Department of Family Medicine, as well as a director in the Physician Learning Program and the Lifelong Learning Program. The Physician Learning Program and the Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare professions, and everyone committed to providing the best care for our patients. I'd like to start off with a land acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Métis, Stoney, Iroquois, and Ojibwe, lands that are now known as parts of Treaties 6, 7, and 8, as well as the homeland of the Métis. The University of Alberta respects the sovereignty lands, histories, language, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. For some housekeeping, I would like to provide some information. Please use the chat feature if you have a question about technical difficulties or L3 programs and services. If you have a question for the speakers, please use the Q&A feature of the webinar. Review what has already been submitted and don't repeat the exact same question, just upvote questions that you'd like answered. We cannot guarantee the panelists will be able to respond to all of your questions, but we'll try. A recording of the webinar will be sent by email to all of those that have registered. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool. And for information, visit the QR code on your screens. This activity has not been formally reviewed by the College of Family Physicians or the Royal College. However, it is eligible for non-certified credit. And Main Pro Plus credits may be earned by completing a linking to learning exercise. So today we're very pleased to welcome our speakers, Dr. Darren Lau, and me. I'm Donna Manca. I introduced myself earlier. And we'll be providing an update on Teams for Health, integrating diabetes and kidney care. Now, we are very fortunate to hear from Dr. Lau. He is an assistant professor, a general internist and diabetologist, as well as a clinical epidemiologist at the University of Alberta and the K Clinic. Darren is also an acting medical director in the Physician Learning Program and the L3. Apart from his research on outcomes of medical therapy in adults and diabetes, he enjoys sharing the newest and greatest things in diabetes with anyone who will give him the time of day. Darren has focused his research on very meaningful things that impact us as clinicians in our practice. Both of us have no conflicts of interest to declare, other than we are conflicted in that we want to improve diabetic care, and hence this work. Thank you so much for your time, and welcome to our PLP webinar.
Thank you so much for that wonderful introduction, Donna. Again, I'm Darren Lau. It's a pleasure to meet you all virtually in this forum. And I'm very excited about this talk and this series of talks, not least because, again, our talk on March 4th is a Bring Your Own Case, Talk BYOC. And I'm looking forward to seeing what you, our audience and community providers, provide in terms of interesting or tricky cases that you'd like us to comment on. So I'm really looking forward to that particular format. But okay, today we're talking about kidney care and diabetes, and boy, have there been a lot of developments in the last couple of years. Natasha, I'll take the next slide now. Okay, so the objectives of today, first, we're going to identify newer agents with cardiorenal benefits, and specifically that would be SGLT2 inhibitors. That's almost old news now. What's newer to talk about is finerenone and then most recently semaglutide. We're going to sketch the evidence for the renal benefits of these agents. We're going to apply these agents to our own patients, and then we're going to contemplate how we might ensure that all of the patients in our practice benefit equally from these agents. And in these respects, Donna has lots of interesting tools for you. Natasha, I'll take the next slide. So I thought I'd open with a case. This is based on a real patient of mine, but I see patients like this quite typically in my referral practice at the K Edmonton Clinic. This is MF. He is a 72-year-old male. He's an Indigenous former law enforcement officer. His past medical history consists of diabetes, dyslipidemia, chronic kidney disease, and sciatica. In terms of his diabetes, his A1C is 7.8%, LDL is 1.47, blood pressure is 140/79. His creatinine is 123, making his eGFR 48. His urine albumin to creatinine ratio is 150 milligrams per millimolar. Just a word on the units there. These are, of course, our Canadian units, but the American units are milligrams per gram. And American units differ from a factor of 10. In case you're reading the primary literature and you're wondering how the American units map onto our Canadian guidelines, just be aware that there may be a factor of 10 difference there. The medications that MF is on consists of what you see there: torvastatin, candesartan, insulin glargine, insulin glulicine, so rapid-acting insulin, 5 units 3 times a day, metformin, and sitagliptin. When you ask the patient what his concerns are, he volunteers, many people from my community have gone on dialysis. And so that's something he's seen and is keen to avoid. So we pull up the online calculator, and there's one calculator that's getting a lot of traction right now, and that's the Kidney Failure Risk Equation, KFRE. This was developed using administrative data sets in Manitoba by nephrologist Nav Tangri and colleagues. The KFRE produces a 5-year estimate of the risk that someone requires renal replacement therapy or suffers kidney failure. And for Mr. MF, that 5-year risk turned out to be about 6%. So just over 1 in 20 chance that in the next 5 years he needs renal replacement therapy, driven largely by his urine albumin. I'll take the next slide. So I thought I'd pause for a moment and see if any of you all have any thoughts about the case. You can throw up some comments in the chat, despite Donna's specific instructions to save questions for QA. Or you could raise your hand and say a couple of words. So what do you think? What should we do? What are your thoughts on Mr. MF? No takers yet? Is it too early? I'll give it a couple more seconds to see if there are any takers.
I think we have one person with their hand up.
Oh yes. I'm not. Oh, okay. There. Let's see. I'm trying to find the attendee list on my screen.
Oh, right. Yeah, go ahead. You should be unmuted and able to speak.
Yeah, I don't know if they can hear me.
Oh, we hear you perfectly.
Okay, excellent. So thanks a lot for inviting us to this presentation. And just to avoid delays, I'm gonna be specific on the topic because of what I see His blood pressure to start with, I'm starting from up there, needs more care. It's not on target. Looking at his systolic. Diabetics would want that, if possible, under 130. The diastolic is fine. So that is one. So we might have to look at his medication, see if we can get that better. Number two is his weight. He's definitely, overweight, and that is something that we should address. Going down, looking at his A1C, at least based on everything else. I mean, if it wasn't for everything else, maybe yes, would accept it. But with these issues, his kidney function is definitely deteriorating. And one way of improving that, apart from improving his blood pressure, is addressing his A1C. So look at his medications, try to improve that. And the hope is that, yes, if we can improve his blood pressure, improve his A1C, we might arrest, at least delay deterioration of his EGFR and improve his A1C, the UACR. And as you've already indicated, the agents that you've highlighted, and all of them can be used in this situation. So I think I'll end it there for now. So I'll allow my colleagues to make comments. Thank you.
Dr. Magurwa, I really appreciate a very systematic approach to this patient. That's fantastic. I agree with all of that. And a couple of things I want to bring out from your comments. The UACR you mentioned is something that is potentially actionable. And that is true, because many of the kidney protective agents we have, you might be waiting to see the impact on EGFR decline. You might never know if it's made a difference in EGFR decline, because obviously you don't have a counterfactual world where you have the same patient where you didn't give them the special agent. But one thing you can see right away often with starting a new kidney protective agent is that the UACR improves. And that's something you can bring to your patients and say, hey, your kidneys are less leaky than they were before, and that's good for the future, right? So that's really cool. Cheryl Carl says, consider use of an agent beyond glycemic control offering renal benefit. Yes, we're going to see where the guidelines position medications with renal benefit versus glycemic control. And it's a brave new world out there where it's kind of, we have the luxury. Glycemic control is hard, but we have the luxury of options that address end organ function now. And, after we get these agents on, sometimes glycemic control isn't an issue anymore. Yeah, add SGLT2 inhibitor for renal protection. That was from Ghulam Mustafa. Oh, absolutely. Okay, this is great. I love where everyone's at. Let's flip the next slide. So what I want to point out is that ACE inhibitors and ARBs have been the foundation of our kidney risk protection in diabetes for 20 plus years now. Based on seminal trials in the early 2000s, late 1990s. But despite ACE inhibitor and ARB therapy, there exists a high degree of residual risk present. So despite maximally tolerated ACE and ARB, and we see this in the current generation of trials as well, at 2 years in high-risk individuals with severe albuminuria, the risk of a doubling of their serum creatinine sustained or needing renal replacement therapy or of a renal death is up to 15%, again, despite maximally tolerated ACE inhibitor and ARB therapy. We have another comment from Carrie Ann Wright. We want his LDL less than 1.0. That is interesting. The usual targets, I think, for primary prevention are 2.0, 1.8 LDL in secondary prevention. I haven't heard about the 1.0 target, but that is, if you know something that I don't, let's bring that back. Let's come back to that. Okay, next slide. I want to point out that this residual renal risk is cardiorenal. So as EGFR worsens, as albuminuria worsens, what people end up dying from is not kidney failure, it's cardiovascular events. So worsening kidney function, albuminuria are both independent predictors of cardiovascular risk. And what we're really doing here when we're addressing CKD is we're addressing future cardiorenal risk. Next slide. So that brings us to the new kids on the block. And the wonderful thing about all three of these class of medications is that they not only offer renal risk reduction, but they offer cardiovascular protection as well. And since most individuals with chronic kidney disease end up having cardiovascular disease as a big source of morbidity and mortality. That's what's really made these agents important to us. So first, let's talk about SGLT2 inhibitors. I'll take the next slide. I don't want to belabor the point. You probably have heard about this in many other talks. You probably use a lot more of this in practice. As a general internist, we were almost late to the party. We started seeing these in our hospitalized patients before we started using them. But I think the family docs have been very quick to pick up SGLT2 inhibitors. I just want to remind folks about the seminal Credence trial published in 2019. This was a kidney outcome trial, enrolled high-risk patients with severe albuminuria, so urine albumin to creatinine ratio greater than about 30 in our units. And it made its primary endpoint, that 3-point nephrologic outcomes endpoint, which consists of 50% loss of eGFR sustained, or renal death, or initiation of renal replacement therapy. And they found that the number needed to treat was 25 individuals with canagliflozin 100 milligrams over 2.6 years to prevent one case of that adverse kidney outcome, which is clinically significant. And by our prevention standards, 25 people to prevent a big important thing is quite a steal. I'll take the next slide. The mechanism of benefit is thought to be reduced intraglomerular pressure. Now, remember, in diabetic kidney disease, the pathophysiology is thought to be, at first you get hyperfiltration. The kidney function looks better than it actually is, and that's because of high pressures in the glomerulus. But over a long period of time, that pressure damages the filter. You get albuminuria, and then kidney function eventually falls at a continuous rate. And so one of the mechanisms by which SGLT2 inhibitors and finerenone, for that matter, is thought to work is by reducing intraglomerular pressure. What that tends to mean is that on paper, when you start an SGLT2 inhibitor, you do see a dip, a reduction in eGFR upfront. On average, that's about 4 points. It's uncommon to see more than a 30% reduction, but interestingly enough, a 10% reduction was fairly common, observed in about 30 to 40% of individuals. And in the DAPA-HF trial, which looked at heart failure and dapagliflozin, individuals on dapagliflozin who had a 10% or more dip in eGFR actually had better outcomes compared to those who did not. So again, possibly reflecting that this is the group of patients in whom there was a successful reduction in intraglomerular pressures and improvement in long-term hemodynamics. So our guidelines currently recommend that SGLT2 inhibitors, I should rephrase this. You're going to see new guidelines soon. Diabetes Canada has updated its kidney guidelines. Those are going to be published very soon, okay? And I can tell you right now, I saw the preview of these guidelines at the Diabetes Canada meeting just in the fall here. And what we're going to see is a recommendation that SGLT2 inhibitors be prescribed in adults with eGFR 20 to 45. Okay, forget about albuminuria, eGFR 20 to 45. So that's how low the eGFR threshold is now for starting an SGLT2 inhibitor. Or eGFR 45 to 90 if the albuminuria is at least is high enough. So 20 is the typical cutoff, and that's based on the most recent kidney trial, and that would be EMPA kidney. Okay, so yes, SGLT2 inhibitors for chronic kidney disease and diabetes. That's a big yes. With that eGFR lower limit being pushed down progressively. Okay, I'll take the next slide. I think we've talked about this already. The point is that, yes, upfront, if you choose to monitor upfront, yeah, you're going to see a bit of an eGFR dip, and most kidney doctors are willing to accept a 20 to 30% eGFR dip, because what we see in the trials is that despite that dip, long-term eGFR is preserved. And it only takes about 18 weeks before that's evident. And this was, again, from EMPA kidney. Okay, I'll take the next slide. The next class of agents I want to talk about is non-steroidal mineralocorticoid receptor antagonist, NSMRA. And right now, we only have one licensed agent in this class, and that would be finerenone. The trade name is Kerendia. It is marketed by Bayer. I'll take the next slide. I guess it's Bayer if you speak German. Anyways, mineralocorticoid receptors are implicated in multiple pathologic pathways responsible for heart and kidney disease. This is known fact. And the thinking here is that blocking these receptors might fix a lot of these pathways, and definitely has a big role to play in heart failure with reduced ejection fraction, where eplerenone and spironolactone have proven mortality benefit, right? But the case is different for chronic kidney disease in diabetes. I'll take the next slide. People have looked into traditional steroidal MRAs for chronic kidney disease and diabetes, and the conclusion is there might be benefit. The evidence is inconsistent. The benefit doesn't appear to be huge. There definitely is a big risk of hyperkalemia in the chronic kidney disease population. Being on one of these agents doubled that risk with a number needed to harm of 41. And then because they're steroidal, of course, you also get gynecomastia and sexual side effects. So the risk-benefit profile purely for the indication of chronic disease is not typically thought to be worth it for steroidal mineralocorticoid receptor antagonists. That'd be spironolactone or eplerenone, unless there are other compelling indications. So heart failure, reduced ejection fraction, definitely. But blood pressure control, it is a pretty good third or fourth line agent, but requires monitoring. That brings us to the next class of MRAs, the non-steroidal versions. I'll take the next slide. So this is a distinct pharmacologic class of mineralocorticoid receptor antagonist that does not hit glucocorticoid or androgen receptors. So it's a much more specific molecule. And as a result of this, there is far less hyperkalemia. It's still an issue, but there's much less of it than with spironolactone or eplerenone, and without any CNS penetration and no sexual side effects. So no gynecomastia, no sexual side effects. Okay, I'll take the next slide. Now, finerenone has been tested in the Fidelio kidney trial. So this is a true kidney trial, which enrolled high-risk individuals with severe albuminuria, but also enrolled a group of individuals with moderate albuminuria, so urine albumin to creatinine ratio of moderate extent, I think greater than 3 or thereabouts, who had reduced kidney function, so eGFR less than 60. So a slightly broader group of individuals than was observed in Credence. And this was finerenone versus placebo. They randomized over 5,000 individuals and followed them for 2.6 years, average age of 65, with a mean eGFR to begin with of 44. I'll take the next slide. And what they found was on the primary kidney outcome, again, that kidney composite outcome, a decided benefit with a number needed to treat of 29. So 29 individuals treated with finerenone, and you would prevent one instance of sustained loss of eGFR of 50%, renal replacement therapy, or renal death. Now, hyperkalemia was an issue that occurred in about 12% of individuals versus 5% of placebo-treated adults. But hyperkalemia leading to discontinuation only occurred in 2.3% of individuals, and there was no real difference in acute kidney injury. So overall, the safety profile was reasonable, although monitoring is, of course, required to catch these cases of hyperkalemia. I'll take the next slide. Similar to SGLT2 inhibitors, we do see a upfront dip in eGFR, but long-term we see preservation of eGFR. I'll take the next slide. Now, there was a parallel Figaro trial, which was a cardiovascular outcomes trial of finerenone that enrolled slightly different individuals. And when you pooled the two analyses together, you get two trials that collectively represent a decent swath of individuals with at least moderate albuminuria, so UACR greater than 3. And you have evidence of both cardiovascular and kidney benefit. And in the pooled trial population over 3 years, the numbers needed to treat were 46 to avoid a major cardiovascular outcome and 60 to avoid an important renal outcome. So demonstrating cardiorenal benefit. I'll take the next slide. So the guidelines the Canadian guidelines will incorporate finerenone. The kidney guidelines already include finerenone in them. This is finerenone. It comes in 20 and 10 milligram flavors. I don't want to get too far into the weeds of dosing and adjusting the dose of finerenone, so you can refer to the product monograph for details or talk to your local pharmacist or pharmaceutical representative, I suppose. But I will point out that the initial dosing depends on their initial eGFR. You can start at 10 or 20 milligrams. Monitoring is recommended of potassium and creatinine in 4 weeks' time, and that was what was done in the trials, and that was proven to be safe in the trials. Some of us are used to monitoring a little bit sooner than that, but that's clinician discretion, and depending on the serum potassium, there are guidelines about what to do with the finerenone dose thereafter. Okay, I'll take the next slide. And that brings me now to glucagon-like peptide 1 receptor agonists, particularly semaglutide, trade named as Ozempic for diabetes and marketed by Novo Nordisk. Next slide. So, of course, GLP-1 receptor agonists, we know them as very impactful medications that provide glycemic control and weight loss without increasing the risk of hypoglycemia. The side effect profile is variable from patient to patient, but mostly consists of gut side effects, although other side effects have attracted a lot of popular attention. Now, those are a little bit beyond the scope of this talk, but I do welcome questions about your experiences using any or all of these agents. And again, we do have a Bring Your Own Case webinar on March 4th, where we can address specific cases that you found challenging because of unusual or severe side effects. The interesting thing about GLP-1 receptor agonists is that they have demonstrated cardiovascular benefits in high-risk individuals. That's really important to us. And it's long been known that these agents reduce albuminuria. In fact, if you include albuminuria as part of your kidney composite, then there's already lots of evidence that these agents improve kidney outcomes. But albuminuria, of course, is a surrogate outcome, and the kidney doctors have always cared more about the hard clinical endpoints. And again, those are held to consist of sustained loss of eGFR, renal replacement therapy, or renal death, right? So for a long time, we've known that these agents can reduce albuminuria, but we didn't have conclusive evidence that they could reduce clinically meaningful kidney outcomes until actually just this last summer when the FLOW trial was published. I'll take the next slide. So the FLOW trial was a trial of semaglutide versus placebo. And this was semaglutide, so in the Ozempic flavor of semaglutide, dosed up to 1.0 milligrams subcutaneous weekly, so the usual diabetes-related dosing. This trial included adults with diabetes and high-risk CKD, defined by eGFR 25 to 75, with urine albumin to creatinine ratio greater than 30, so severe albuminuria by our standards, or greater than 10 if the eGFR was less than 50. And the primary outcome, again, was that composite kidney outcome. Average age here was 67, so these aren't quote-unquote spring chickens. BMI 32, average eGFR at start was 47, and they followed up about 3,500 individuals over 4.5 years, so quite an undertaking, this trial. I'll take the next slide. And they hit their outcomes. The primary kidney outcome showed benefit with a number needed to treat of 22. 22 individuals could be treated with semaglutide at this dose to prevent one important kidney outcome, which again, by our standards of prevention, is pretty good. But more importantly, they also met their cardiovascular outcome, again, indicating that renal risk is really cardiorenal risk. So the MACE, the major adverse cardiovascular event number needed to treat, was 41, and the all-cause mortality number needed to treat was 33. That hazard ratio was also statistically significant. In terms of safety, of course, with semaglutide, everyone's interested in retinopathy risk, and eye disorders were a little bit more common in the semaglutide-treated arm, but diabetic retinopathy events specifically were not different in this particular trial. Adverse events with discontinuation were roughly similar, although, of course, individuals in the semaglutide-treated arm had far more GI side effects, and those were primarily what led to discontinuation. 1 in 10 in the trials, in my practice, maybe a bit more, right? I'm sure in yours as well. Next slide. Okay, so what do the guidelines have to say about all this? I'll take the next slide. This is a figure from the KDIGO guidelines, the International Chronic Kidney Disease and Diabetes Guidelines. And I think this pyramid is absolutely fantastic because it indicates that, of course, lifestyle therapy is always foundational: diet, exercise, smoking, and weight. But right above that is first-line drug therapy, consisting of SGLT2 inhibitors and ACE inhibitor ARB. These have the longest established benefit in diabetic kidney disease. And then on top of that, we have GLP-1 receptor agonist and non-steroidal mineralocorticoid receptor agonist, additional medications with heart and kidney protection. And then after that, after we deal with the foundations of the pyramid, then we can think about glycemic control and getting that LDL down to target with additional agents. Statins are foundational, of course, but additional work to do that. And then blood pressure control, just recognizing that all of these agents appear to work independent of their glucose lowering and effects, right? In fact, SGLT2 inhibitors in chronic kidney disease, by the time you get to eGFR less than 30, what really is the impact of that SGLT2 inhibitor on serum glucose levels? Probably not that much, but it still has a kidney impact, right? So that's it is a new paradigm where we're focused on end organ prevention with these medications. Okay, I'll take the next slide. Again, Diabetes Canada has upcoming guidelines related to kidney disease, and they're going to say roughly the same thing. You're going to find that ACE, ARB are foundational. SGLT2 inhibitors, GLP-1 receptor agonists, non-steroidal mineralocorticoid receptor agonists have roles to play in diabetic kidney disease. I encourage you to have a look at those guidelines. They also have a wealth of interesting things for the clinician. For example, if you were ever made a little anxious by quote unquote mild hyperkalemia, it's in the red, but it's only 5.2, 5.3. Do I stop all of their kidney protective agents? And so the guidelines are going to come right out and say mild hyperkalemia. Most nephrologists won't bat an eye, not to worry too much about that, right? So I do encourage you to have a look at those guidelines. Lots of interesting things. And again, urine albumin to creatinine ratio we know is undermeasured in our patients, but each of these medications individually can be expected to have about a 30% reduction in urine albumin, which has prognostic implications for progression of chronic kidney disease, but is also something you can point at and show your patients and say, hey, I know you're taking an additional pill, but this is what we see for your kidneys. You can actually see that there's a reduction in that leakiness, which is really important to us. Okay, take the next slide. Here's another resource for you. This is the Alberta Diabetic Kidney Disease Clinical Pathway. There's a link right there. This presentation will be available on YouTube, so you can find the link there. You can take a screenshot, a snapshot of it now. This pathway looks a little busy, but it's actually pretty reasonable to walk through. This was developed with input from users, including yourselves, or individuals like yourselves. And this is something that PLP worked on with Strategic Clinical Network. Is now defunct, but it lives on the AHS Pathways hub, and it'll walk you through. You're dealt with diabetes. Okay, are we prioritizing kidney protection, heart protection, or then A1C optimization, and then the sort of agents you can think about with hyperlinks to other pages in the PDF where you can look at prescribing information and recommendations and risk-benefit trade-offs tables to talk to your patients about. One thing about this pathway is it does not yet include semaglutide, but we have a version of this that has a blank spot for semaglutide, and we expect to do those updates this summer, okay? So there's a resource for you all, and that's locally developed. I'll take the next slide. So let's come back to this case, Mr. MF, who has the patient-centered priority of avoiding avoiding worsening of his kidneys. Well, there's lots of room to add on some additional agents. Obviously I don't want to overwhelm him with new pills or injections to take. I think definitely SGLT2 inhibitors would be a good place to start, maybe dapagliflozin 10 milligrams. And then because he is overweight and he is on insulin, whenever I see someone on insulin, I'm keen to see if I can try to wean down that dose of insulin, or even if, get them off of insulin. And sometimes with additional therapy, we can do that. And that's a much safer set of medications to be on. So we might start Ozempic here as a next step to see about reducing his insulin doses as well, while maintaining better or similar glycemic control. Okay, I'm going to stop there, but I'm going to ask for the next slide and pass it over to Donna for her thoughts.
So typical patient that we see in our practices, right? And I always think of that pyramid. I love that pyramid illustration that Darren illustrated. Going back to that, really lifestyle is key with this fellow. And we don't know a whole lot. There may be information maybe that is known, but I find a lot of times the big problem is the diet. And I have a lot of diabetics, and Darren knows, of steel-cut oats and things that raise blood sugar because they're not eating any protein or anything with it. And its diets are, restrict any fat, and we've gone that way. So now we're seeing more high blood sugars, and people don't know what they should eat. The other factors here is does this person smoke? And that is a very big one, that we could address. And then alcohol can also contribute to elevated blood pressure. So when I have patients whose blood pressures are not coming down, I always revisit the alcohol question because sometimes, I didn't detect it on previous times. Exercise can also have a good impact, and walking after a meal. Now, with patients that have early kidney impact, I really like the kidney pathway to guide me, and I will refer to a nephrologist. So I probably would have had referred to a nephrologist as soon as his albumin creatinine had gone above 60 or his glomerular filtration rate goes down. I want to really work with him on optimizing medications. Now, this is an older fellow, and something that often happens with our patients is we continue medications when they're no longer useful. We also have to consider starting at lower doses in our older patients, because it puts them more at risk if we go right to the regular dose and they have multiple medications on board. So I would look at his medications and think, where am I getting the most bang for my buck? And discuss with him what better choices there might be. And certainly in this case, the SGLT2 and the GLP, I think are much better options for both the heart, obesity, kidney, and blood sugar. The other med is the other blood sugar lowering medication, not so good, and I would stop that. Other factors in this fellow, he's obese. And other things to think about would be, does he have liver impacted from the obesity? Liver functions be good to look at. And is there sleep apnea? So lots to think about here. Next slide. This is an illustration of a tool that I really liked when it came out. Now, caveat is it is getting a little old. It hasn't updated information on more new drugs that really have improved impact. But it can guide you as to which meds to focus on prioritizing and stopping. It gives you little happy faces so you can see which drugs improve symptoms, and you can see most of the drugs we give don't improve symptoms. But some of them reduce the risk of future illness, and that's the key here. The other problem is some of them can cause harms, and certainly insulin in this fellow can be a concern. We have a fellow that's obese, and as you know, it makes him more hungry and can contribute to that. So I find something like this useful to think about which medications I might look at reducing or stopping. And what's nice about it is it tells you how you can stop the medication. Can you stop it suddenly, or do you have to gradually stop? And it gives some advice about that. Next slide. So when dealing with elephants, and all of our patients are elephants, we have to do one spoon at a time, right? We're not going to spend the whole day with that patient to correct the situation. It's going to take time. We give little bits, we share ideas, we bring them back. And it's not one person that can do it all. I can't do it all. So I find a team approach is really important. But when you have a team and the patient is included in that team, you need to be on the same page. And I found there's some excellent tools. Diabetes Canada has resources that you can pull and develop a care plan with your patient and bring the team together to agree to that plan and optimize it to that individual patient. Next slide. This is an example of what I'd call a care plan. And on this plan, it shows, what you and the patient and your team decide to focus on, and you can send the patient home with this, a copy of this, and so that everybody is on board and is focusing on the same thing. And this needs to be updated with each visit or over time. Now, it can be difficult to have this paper separately, so what I like to do is I built a lot of this. Our team built it into our electronic medical record. Next slide. So with Med Access, we have a goals page, and on the goals page, we were able to input a lot of this information so that when patients come in, you can look at your goals page, and if you see a red, you know, oh, that's not being met, and you can prioritize what you're going to focus on in that visit. And everybody has access to that information so that the team is aware of what the plans are. Often I've had residents in training come and complain that they don't know what's going on with the charts. They come to see patients. Diabetes isn't even in the medication, or in the profile. So they don't know how to manage the patient, and that puts our patients at risk. We often know our patients and maybe we can manage, but if we have somebody else that's covering our practice or that without these treatment plans and goals, often they don't know what the aims are. If you don't have access to a goal sheet in your EMR, in the profile, you might be able to write in your own goals. I've done that with my cancer patients because I don't have the ability to do that on the goals page, but there are ways to use your EMR smartly. Next slide. So we talked about the individual. We're going to move on to information and data, and we're going to look at the panel, So when we try to improve practice, we need to know more than the patients that we're seeing. We need to understand the panel. Next slide. Years ago, I think in about 2009, a number of us were research directors in family medicine across Canada, and we were frustrated that our learning health systems did not have resources for us to do appropriate research or quality improvement or surveillance on our practices. We just don't have the infrastructure funding. So we got together and we obtained funding and developed the first Canadian multi-disease electronic medical record surveillance system across Canada. And this is in pretty well every province and coming up in Saskatchewan as well as the Northwest Territories is being developed. Next slide. So what CIPSIN, which is this pan-Canadian network, does is it has a number of practice-based learning and research networks across Canada working with family physicians to take data out of electronic medical records, structure that data, and enter it into a relational database for point of care information that can be used for surveillance, quality improvement, and research. And the individual networks can provide the participating physicians with feedback back on how they're doing, as well as can provide them information so that they can link back to their individual patients. Alberta has 2 practice-based learning and research networks contributing. NAPCRIN is the northern one, and that's the one I'm the director of. And then in southern Alberta, we have SAPCRIN. It's sugary. NAPCRIN's nicer, though. It starts with N. Sorry, we do compete with each other. Next slide. So NAPCRIN is able to let you know how well your chronic conditions are coded in your problem list. And this is really important. This is what I call meaningful use of your electronic medical record. If you don't have chronic conditions like diabetes in your problem list, when somebody comes to cover for the practice, it's not easily seen and they don't know if the patient has diabetes. We've developed 24 validated case definitions for those different chronic conditions, including blood pressure, COPD, asthma, and so on. We can tell the physicians which patients have not been entered that we think have the conditions so that we can help them update their electronic medical record. And then they have a disease registry that they can use to see how their diabetics are doing and to do panel level management on. Next slide. Now, going back to the individual, we've been very lucky to collaborate with PLP, and PLP has provided excellent resources so that we've been able to develop reports on numerous chronic issues that we send to our participating sentinels. And this is an example of a report around diabetes and renal failure. And you can see in this report, it illustrates how the physician, which is the dark blue, is performing in terms of SGLT2 prescribing compared to their practice, compared to the overall network. And we can provide that physician who has not been prescribed SGLT2 so they can do improvement. And we have done that with various PCNs. We've worked with PCNs to help them improve profiles, as well as some of them have done quality improvement in this area. Next slide. Darren has really used this resource and has done quite a few publications on how we are prescribing in our patients with diabetes and renal failure and how we're meeting other targets. And you can see we're not prescribing SGLT2 inhibitors as much as maybe we should be. And we see a lot of sometimes areas where we're not doing as well. Now, that's not because we're bad family physicians, not at all. That has a lot to do with these crazy policies that impact our ability to optimize care to our patients. And Darren has even published using the SIPSN data and our data across Canada on 3 provinces and how various prescribing occurs in the different provinces. And these outdated policies have a negative impact on our care, which can hopefully change things. Next slide. This is just a pictorial of what family physicians can do if they're interested in research. They can just join the network and get information about projects. They can contribute data to the network. They can be involved in quality improvement, and they can collaborate on research projects such as Darren even has. Next slide. The College of Physicians and Surgeons requires practice improvement program requirements that we have to report on, and we get that every year. So there are 3 projects that we need to complete over a 5-year cycle. And the key elements are illustrated here. There is a template to develop an action plan, that can help get you started. And there's a link to the college's resources. Next slide. The Federation of Medical Regulatory Authorities of Canada developed a 5-step system for improvement, and you can see the steps here. This is a process, to assess your practice, create a learning plan, then implement it, evaluate, and then recommendations for future and how you can change things. This has been implemented across Canada through the various regulatory bodies. And you can see it's a process. It's not something you can sit down and do in a day. It's something you have to do over time. And the My Lifelong Learning Plan facilitates each of these 5 steps, so it can help you. Next slide. It's a free online tool, and there's a link to it here. And it can help you complete your improvement cycles for the 3 required QI projects. It's accredited for up to 36 Main Pro Plus. For the practice-driven, it's accredited for up to 24 Main Pro Plus credits. So you can do one on optimizing prescribing in your patients with diabetes and renal failure. So that's an excellent topic for you to consider. Next slide. You can register, just scan this QR code or link here, and this will be available as well when you go revisit this presentation. Next slide. And Darren, take it home.
So I think I'd like to conclude with the following key messages. First, SGLT2 inhibitors, finerenone, and semaglutide reduce residual cardiorenal risk. And that's really important. We live in an era with a luxury of options, and I suppose we might be limited by side effects and what our patients can tolerate in terms of how many pills you want to eat in the morning. But there are lots of options now that we could apply to reduce kidney risk, which really is heart and kidney risk in the future. Monitoring of potassium is important, particularly with finerenone. With most of these agents, we can expect and tolerate an eGFR dip between 20 and 30% as the upper limit. And consider the upcoming Diabetes Canada guidelines or using the Alberta Diabetic Kidney Disease pathway, bearing in mind that that will hopefully be updated this summer to include semaglutide to help guide your cardiorenal risk reduction in adults with diabetes and chronic kidney disease. And finally, monitoring your quality of kidney care in your practice might be a very accessible CPSA quality improvement project using some of the resources that Donna's described. I think we're ready to take questions.
And we're ready to take questions. So I think our first responder was very early on, Jennifer Coppins, is fully in support of the SGLT2 and GLP. However, as we all know, the process Blue Cross offers. So wondering if there's any progress here.
So we now have a generic SGLT2 inhibitor that's dapagliflozin, and that is a regular benefit under Blue Cross. If they have Blue Cross funding, you can prescribe dapagliflozin, and there's no paperwork that needs to be filled out. So that's a big deal, and that happened, I think, in the end of 2023. Ozempic, semaglutide, GLP-1 receptor agonists, it continues to require special authorization, and you do have to fill out that form. A1C above target, trial on metformin or tried metformin, tried some second line agent, inappropriate for insulin. Usually most patients who look like Mr. MF, I can, that's pretty easy to sort out for, but yeah, to be fair though, in our own research work, we've demonstrated that special authorization requirements roughly cut prescribing by half in patients for whom there is end organ benefit. So yeah, we know this definitely is an issue that special authorization hasn't necessarily caught up with where the evidence is.
And thanks, Darren. Joyce Lamb says thank you. She has a question regarding the keto pyramid and wonders if about choosing metformin as foundation versus the newer agents like SGLT2 inhibitors, and your suggestions what an initial medication should be.
Oh, that continues to be hotly debated question. I think in someone with end organ comorbidities where there's that hard end organ benefit, we probably have better evidence of cardio kidney protection with SGLT2 inhibitors than we do with metformin. And the American guidelines, for example, have gone that way. Use the most appropriate agent, and where they're less stuck on starting with metformin. For whatever reason, my feeling is the Canadian guidelines will probably come out and stick with metformin as first-line therapy because it's relatively safe, lots of experience with it, and it did show cardiovascular benefit in the UK PDS, that subpopulation of that trial. The question you describe is still debated to this day. And that is an individualized decision. I will point out that metformin does have a host of side effects, including GI side effects, diarrhea, hypomagnesemia, B12 deficiency. And so occasionally I get a patient referred to me and they've just been putting up with diarrhea for years. And then when I hear this, I say, well, why don't we try stopping the metformin? Giving them permission to do that, because a lot of people will never, ever stop their metformin. That was the very first medication their diabetes doctor put them on. And giving them permission to do that sometimes really improves their quality of life. So I'm sorry to say I don't have a firm answer to that question for you. And that still remains an individualized choice, but I could see it both ways. I would definitely prioritize getting those impactful agents on board: ACE, ARB, SGLT2 inhibitors, semaglutide, finerenone. And if metformin is going to get in the way of that, there's a good argument to be had for starting on something else. For very practical concerns, though, a lot of our special authorization Blue Cross forms require that patients already be on metformin, so our hands might be tied there.
Thanks. And Terry Cote-Hilo, and hopefully I didn't wreck your name, sorry, says, I have a patient with diabetes and high ACR and a normal glomerular filtration. He is on an SGLT2 and we started Kerendia. He did great on that. However, his wife's plan that covered the drug was lost. So we applied to NIHB for coverage. It was denied, as we need to say we consulted with a nephrologist. The patient doesn't really need to be referred to nephrology clinic at this point. We just need to say we consulted with a nephrologist. How do you recommend what we do on this?
Wow. What a horrible spot that puts you in. Because one way of doing it is to, I think there's a telephone consult service you can use. Donna, I don't know if you remember the name of it. But it might be good for non-urgent quick phone advice where the turnaround time is, you need is within like 24 hours or something, as opposed to urgent consult advice where you call whoever's on call for the hospital, right? But I got to say, I can't imagine, this is an easy call to make, like, hey, I don't want to bother you during your busy day. So that's really challenging when the insurance companies give you, restrictions like that seem a little unreasonable. If he has Blue Cross coverage, that's not a criteria for Blue Cross coverage, but I suppose he's probably not above the age of 65. So that's a challenge. I think you got to do the best to meet that criteria, and you might try to use a telephone consult service. Is it Specialist Link? Is that the consultation service, Specialist Link?
And I can't remember, it's electronic too. Like there was one you could do through email, if I remember right. So there is e-consult, I think.
Yeah.
And I've done it with nephrology, not with urology, but I can't advise how to do that.
Mm-hmm.
Remember, I'd have to look into that.
What a challenging spot, right? Yeah. Okay. Good to know that that's a thing. Gee.
Yeah. It's frustrating. It's common, these kind of problems. There's an anonymous request. Please comment on drug-induced hyperkalemia. What level did you mention would be acceptable as being safe, and how often should it be the potassium be monitored?
Yeah. Yeah, so, the monograph says when you're starting something like finerenone, you monitor after about 4 weeks. And a mild degree of hyperkalemia, 5.2, 5.3, up to 5.3, would be considered reasonably safe so here's the caveat, in a stable patient. So obviously if someone has something acute going on and then you catch the hyper-K, but they're not eating, they're not drinking, they're not peeing good, they've just taken a bunch of ibuprofen, who knows, right? Like that's a bit of a, work in progress, like that's dynamic. But presuming your patient is well and stable, mild hyperkalemia, I've had the experience where the nephrologist just kind of shrug and ignore that, right? There is a personal risk threshold involved, and of course, you may or may not be as comfortable with that, and you could consider dose reducing the finerenone or adding SGLT2 inhibitor, which tends to have a diuretic and lowering potassium effect. So that's a good combination to have with ACE inhibitors and finerenone to try to blunt that, right? So there are some options there.
And Cheryl Carl asks, do you have any thoughts about Mounjaro versus GLP-1 RA inhibitors?
Yeah, that's a hotly debated. Okay, that's an interesting question as well. So tirzepatide or Mounjaro is a dual agonist. So if I'm not mistaken, in addition to the GLP-1 receptor agonist, it also contains a GIP agonist. And as a result, it is actually in the trials, and they've done head-to-head trials against diabetes-dosed semaglutide, so Ozempic. And in these trials, even at the beginning doses of tirzepatide, it was superior in terms of weight loss and A1C reduction. So on these two criteria, it is a superior medication. But here's the big but. The heart and the kidney outcomes have yet to be clearly established in the cardiovascular and kidney trials of tirzepatide. So if you believe right off the bat that there's going to be a class effect, sure, you could use tirzepatide, in a patient like MF. I'm a bit more conservative. I like to wait to see the evidence. I think tirzepatide is fundamentally a different sort of medication. And so for a patient like MF, I will continue to use semaglutide because that's where I have the proven heart and kidney benefit. But certainly in a patient who with no such compelling indications, if they have funding for tirzepatide, then and they're able to deal with the current dosage, administration form, right? Like as far as I know, it's still vial and syringe because they haven't gotten the pens to us yet. I'm not sure if that's still true or not. There are plans to get the pens out to us soon. Then yeah, that could be a very reasonable option. Or someone who's maxed out semaglutide and continues to need more weight loss, more A1C reduction, that could be a very good option, right?
And we have one last question from Jennifer Coppins, and it's what's the cost of finerenone?
Okay. About the same, maybe a little bit more expensive than on-brand SGLT2 inhibitor. So I don't know the exact cost offhand, but I think it's somewhere in the ballpark of 100, maybe a little bit more than that per month. But just check with your pharmacist or look it up on the IDBL. So just Google IDBL Alberta, and that'll give you the interactive drug benefit list. Because it's Blue Cross listed now, all finerenone is sold at the public list price, which is found on the IDBL online. So sorry, I actually don't know the exact list price offhand. Yeah, good question though. That's important for our patients. It's worth remembering that even with coverage, Blue Cross coverage, there is copay. There is a copay. It's capped, but it's per prescription. And so if they get their prescriptions filled every month, that does add up, right?
Well, and that's it. We got all our questions. So we had an excellent webinar with all of you. Thank you so much for your input. Now, remember, on March the 4th, we have another similar webinar, but this time you're going to bring your challenging cases. So think of the case and send it to Nandini. You've got the email link right there. Please send it in by February the 25th. And we're going to make a very interesting presentation with our excellent presenter, Darren, right? And we'll hopefully be able to answer lots of questions or maybe even create new ones. So thank you, everybody. Remember to fill in your evaluations. We do appreciate the feedback. It helps us to improve these sessions. And I hope you have a wonderful day and week. And see you later.
And thank you, Donna, for moderating this and for your fantastic insights. Hopefully we'll see you all next time.